Hello, everybody. My name is Brian DeVeaux, physical therapist, and I'll be speaking about mental health and the return to play process. I have no financial disclosures. The agenda for today will be highlighting the significance of psychological and contextual factors in rehab, discuss potential effective screening methods for yellow flags, educate on crucial importance of psychological measures as a part of the return to play process, and review some potential strategies in the clinic when working with athletes with kinesiophobia or higher fear. Mental health disorders are on the rise. As we can see in this graph, some of the higher issues are musculoskeletal as well as mental health disorders. Mental health disorders, definition of this would be more feelings, thoughts, behaviors that are distressing, dysfunctional, atypical, with 1 out of 20 people having a serious mental illness daily and 1 out of 5 people experiencing mental conditions within the year. Some things we may encounter with athletes include mood disorders, anxiety, eating disorders, sleeping disorders, and psychosomatic issues. So we want to be a biopsychosocial clinician. We want to acknowledge the diagnosis in biology, but also the psychological status of the athlete, as well as the contextual factors as well. When looking at the different flags that we may encounter, such as red, orange, yellow, blue, and black, today's lecture is going to more highlight the yellow flags, such as beliefs, appraisals, and judgments, emotional responses, pain behavior, including coping strategies. Some definitions and things you may want to look out for includes explanations or expectations of poor treatment outcomes, increased worry, fear, and anxiety around the pain and diagnosis, as well as over-reliance on passive treatments. A study done by Chad Cook and all highlighted this quite well. Took the ICF model and adjusted it into the drivers of pain and disability, called the pain disability drivers model, and basically broke it up into 5 domains: nociceptive pain drivers, neuropathic pain drivers, comorbidity drivers, cognitive and emotional drivers, and contextual drivers. What was interesting about the study, first off, it's a great thing to utilize as a base for initial evaluation, but also they saw a crosstalk. So improvement in one area seemed to help other areas. So improving the patient's cognitive emotional status seemed to help with their nociceptive pain as well. So some definitions to discuss include kinesiophobia, which is a pathological fear of motion. And we can see the graph here that outlines fear avoidance, where we have the injury, then the pain experience, and if the athlete more catastrophizes on this pain, then we can lead to fear avoidance, whereas if they can get to a point of lower fear, they can confront the issue and recover. And as per ISP, the definition of pain is a sensory and emotional experience due to actual or potential tissue damage. So discussing on screening, we probably want to start screening on day 1 in terms of like if we suspect any kind of increased fear and yellow flags. First and foremost, expectations. Poor expectations is linked to poor outcomes in rehab. So we want to make sure that the expectations aren't too high or too low. We want to make sure they're reasonably where they should be. And even the patient questions such as like, what are their expectations in rehab? Do they feel they can recover? And maybe even like, what do they think they need? Because they may have went to other rehab facilities where other clinicians worked with them. And maybe certain things helped them where others didn't. Other tools we may use include the OSPRO tool, optimism versus pessimism, the PSEQ, FABQ, PCS, PSFS, and the SANE scale, which will outline a few of these momentarily. So the OSPRO tool, the optimal screening for prediction of referral and outcome, is a great place to start if you suspect the athlete has increased fear and more potential yellow flags. Whereas the pain self-efficacy questionnaire more outlines poor pain coping skills. The pain catastrophizing scale outlines athletes that may be more ruminating or obsessively thinking and focusing on their pain. And evidence shows people that have this situation as well as poor optimism may require additional assistance in their rehab. The patient-specific functional scale is a great scale and tool to utilize for goals. Commonly, we can have them state their top maybe 3 goals that they're limited in terms of function and rate them accordingly. And lastly, doesn't have its own slide, but the SANE scale is an excellent way to find out where the patient stands either in the beginning and or at the end, asking them from 0 to 100% in terms of their functional ability with activities of daily living and or athletics, where they stand. So example, let's say they say they're 85%. You can say, okay, so what's the last 15%? What do you feel is limiting you to go back to sport? And you'd be surprised, some things they say. It could be things you can replicate in the clinic in terms of exercises, or it could be something more of like a psychological reason. So now we're returning the athlete to sport. There are multiple factors involved in this. Some of these include strategic assessment of things like demographics, past the current injuries, type of the sport, and position. Also, like what we're discussing now, assessment of the psychological readiness, but also there's the objective measures, range of motion and strength, physical performance measures, such as maybe hop testing, and lastly, education on injury prevention. Some outcome measures for return to play when we're getting closer to the finish line, more specific to return to sport, include psychological readiness to return to sport scale, the ACL-RSI, the newer hip-related RSI, the HAGOS, and the TSK-11, which will outline some of these as well. First off, the psychological readiness to return to sport scale is based off basically any kind of injury that we may encounter, and scores between 50 and 60 suggest the athlete is psychologically ready to return, whereas below 50 suggests they may need more time to recover. The ACL return to sport inventory has become a lot more popular nowadays and typically is provided around the 6-month range. Some studies show 4 to 6 months, and it's a useful tool. One study showed that a score greater than 56 showed greater than 8 times more likely to return to sport at 1 year. Another study showed less than 77 total score had an increased risk of a second ACL injury and may benefit from additional psychological counseling prior to return to play. Studies show ACL has a high reoccurrence and high involvement of fear, with up to 77% fear of re-injury, as well as decreased confidence at 15% and an overall 63% return to play rate. And what's interesting is studies also show that there's not quite a correlation with physical readiness versus psychological readiness, meaning an athlete may have great quad strength but do not that great on ACL-RSI and vice versa. However, the HAGOS score scale tends to have somewhat of a correlation. It's divided to 6 subscales or scores, relevant measurements to the effects of hip and groin impairment. And these results are correlated to hip strength as well as the Copenhagen 5-second squeeze test pain report. It's pictured at the bottom right, and basically it's a physical performance test to screen for groin pain, where you have the athlete squeeze as hard as they can and report from 0 to 10 how much pain they're feeling, with 0 to 2, relatively fine in the green light zone, 3 to 5, yellow light borderline zone, and 6 to 10 out of 10 in that irritable red light zone. So therefore, like a lower score in the HAGOS, you'll see probably more pain reported with the squeeze test, and with strength measurement, weaker adductor and abductor strength. So it's quite nice with that correlation. The TSK-11, Tampa scale for kinesiophobia, it's quite useful scale. It's correlated with multiple body regions and studies, including starting in the low back, as well as further research with the neck, the knee, particularly PFPS or patellofemoral pain syndrome or ACL cases, the shoulder, particularly shoulder instability, the hip, ankle instability issues, and even concussion. With studies showing with concussion you can have increased fear of kinesiophobia that can correlate to decreased reaction time. For the ACL, greater than 19 points total score suggests a higher fear of kinesiophobia, and also is correlated with a 13 times increased risk of second ACL tear within the first 24 months. So again, quite useful scale, typically given towards the end of rehab when they're getting into that return to sport phase. So characteristics of peak performance state in sport. So these are some terms that we want to get the athlete to. Include focused, fearless, automatic, immersed, confident, in complete control, time and space slows, relaxed but energized, and able to regulate emotions. So some strategies in working with a fearful patient. Some things that you can do includes motor imagery, basically having the athlete visualize, close their eyes, picture themselves on the field, on the court. They're going through their different movements and competition, symptom-free, high confidence, and high success. Also positive self-talking, helping motivate themselves, breathing and stress management, educating on proper diaphragmatic breathing and stress coping. Effective communication, again, highlighting proper expectations and also highlighting as they're meeting the goals and passing their return to sport tests. Program compliance and motivation, making sure we're empowering athletes all when we can. encourage an active role in decision-making, making sure we're having more of a shared decision-making approach with the athlete and their rehab. We want to address athletes' emotions. We want to show empathy. We want to reassure them that being nervous going back to sport is quite normal and common. We want to be goal-oriented. We want to establish realistic short and long-term goals and make sure we're testing meeting up to these goals. We want to make sure we're reminding them on recovery, proper sleep, nutrition, hydration, again, managing their stress levels. Some patients may benefit also from pain science education, particularly ones that score lower on the PSEQ, such as poor pain coping skills. An example would be educating them that not all pain is tissue damage, could also be sensitivity. A nice analogy is explaining pain is equal to like a smoke alarm that's sensitive. And last but not least, ongoing communication with the sports medicine team is crucial, or be it the athletic trainer, physician, because there are some athletes that may require further referral to a mental health provider, such as the sports psychologist. So take home from the lecture, we need to screen for potential cognitive, emotional, and contextual barriers to treatment and monitor them throughout rehab. We probably want to start, if we can, on day one, because just as much as like an ACL case, their quadricep muscle may change, so may their psychological status. We need to also screen for psychological factors as a part of return to play decision-making, being the statistics we saw with high injury rates. And also remember, these factors may be independent of the physical performance measures. Someone may do well on a hop test, may do well on a quad strength assessment, but maybe not so well on the psychological readiness. Thank you.